So next we have Dr. Alessandro Crocoli, who will be here to present on the choice of vascular access in children.
Good afternoon. Thank you for inviting me to have this speech here at this prestigious conference. I would like to talk about the difference between the adult and the children. And I start telling you that I have to be very clear about this. When we talk about vascular access in children, we are not just scaling down adult practice. Children come with a completely different reality. A smaller vein, evolving physiology, and importantly, a much higher emotional burden, both for the children and for the family. And every time we fail, it's not just a failed attempt. It's fear, it's pain, and it's a step closer losing a future access. So that's why this decision matters sometimes more than we think. And so, another key aspect of children is the physiology. In early life, higher extracellular fluid progressive shifts toward intracellular compartment, and this has a direct implication on fluid therapy and on drug distribution, which means that the vascular access is not just where to put a catheter. It's a part of the treatment strategy for the children. And so what happens in real life? In real life happens that we try once, and then we try again, and we try again. And if we don't have success, we realize that we are not treating the patient. We are just chasing a vein. And in the meantime, the patient is a child and is in pain, the family is stressed, we have a lot of problems. And also, his venous capital is disappearing. So the problem is not a technical failure. The problem is that we are starting with the wrong strategy. We are not proactive in these patients. So if I have to summarize this concept in one sentence, it would be this: the right device for the right patient at the right time. And I want to stress this. This decision should never be driven by what we are used to or but by what is available in this immediate situation. It should be driven by a clinical reasoning. Again, we have to be more proactive. The decision in a kid should consider different issues like, duration of therapy, type of infusion, if it's vesicant, the osmolarity, the pH, the patient age and the size of venous access, the availability of the venous access, the clinical setting. It's not just a technical act, it's a clinical decision-making process. And so we classify the VAD in the same way for the adult. So we have the classification based on tip location, not based on the insertion site. So we have peripheral, short, long, and midlines, and central, by the way. And this is very important because it's the understanding of this situation is fundamental to avoid misuse of the catheters, especially in children, for the reason that I've just told you. And for example, if we talk in emergency, probably I'm not the most skilled emergency specialist because I'm a surgeon, I'm not an intensivist, I'm not an anesthesiologist, but in emergency I can tell you when it's very chaotic, it's fast, everyone is under pressure, we still need to think because the speed without the strategy leads to complication that cost much more time to us and to the patient later. So it's very, very important. Regarding the peripheral access, we know that it's appropriate when the therapy is short-term, we have no vesicant drug, the patient is stable, but we know as well that it's not appropriate for long-term therapy, for aggressive or vesicant therapy, and we must bear in mind that overusing a peripheral access is one of the most common and serious mistakes we can have treating children. Regarding midlines, they are becoming more and more common. But probably, on the other side, the midlines are one of the most misunderstood devices. Why? Because they look like a safe compromise, not too simple, not too invasive, but this is exactly the problem, because they are not central line. And when we start using them as a central line, the complication for sure will happen. So midline are useful, are important, but only if we respect their limits, especially in children. And so there is a moment in the clinical pathway of a kid where the question is no longer, can we manage the peripheral line? The real question becomes, are we delaying what the patient actually needs? Because once you need chemotherapy, parenteral nutrition, reliable long-term access, the issue is not more access, it's timing. And so we need a central venous access. And also, for the venous access, we know that we have to choose the VAD according to the scenario. So we can have a peak if we need a medium to long-term access, a cheek in acute patient, ICU, while if we need a more stable access for long-term continuous therapy, we can use a tunneled cheek or a port if the therapy is long-term as intermittent. There is no best device, but the right one for the right situation. And so the process to choose a vascular access in children must be systematic. So we have to confirm indication, make the ultrasound vein assessment, select the site, tunneling when is needed, make a standardized insertion so it leads to no blind choice, no habits, only strategy, okay? And this is very important. And we have also to deal with some pediatric specific issue. This is the pediatric dimension. We are not just treating a patient, we are treating a growing child. And so we have to think ahead. What will happen in 2 months? What will happen in 6 months? Will these devices be still appropriate? Will this device still be manageable by the family? This is why the pediatric vascular access is always must be considered as a long-term decisional process. This is very, very important. Because, for example, in neonates, everybody knows that we can use umbilical catheter, epicutaneous caval catheter, ultrasound guided access, but I would like to show you this manuscript that was written by one of my mentors. There is a manuscript about the surgical treatment of prehepatic portal hypertension secondary to cavernoma of the vena porta. And this is very important because we have a healthy for newborn that for a wrong use of umbilical catheter become a sick child and require a very difficult and hard surgical treatment when possible to restore the normal circulation within the liver. And so today our standard is clear. We have to do ultrasound guided puncture, no blind puncture, no surgical venolysis. I want to stress this concept. I am a surgeon, so I was born and I was raised by my teachers to prepare surgically the jugular vein and the femoral vein. Probably for a pediatric surgeon, it's something that must be in the background, but we don't have to use anymore. This is the damages we can have to prepare when we prepare always and many more times the surgically the vein. And all these kind of situations, so avoid blind puncture, avoid surgical venolysis, use all the minimally invasive techniques, dramatically improved safety and outcome over the years. And so we have also the key rules to maintain vein to catheter ratio 3:1, use the chlorhexidine for the antisepsis, a proper stabilization, the hub disinfection, the flushing protocol. These are all small details that make a big difference, very big difference, I would say. And so, what are the common mistakes? If you look at complication, most of them don't come from rare events. They come from repeat, small mistakes. Choosing out of habit, insisting on peripheral access too long, using the device for the wrong indication, and behind of this, there is the sentence that everybody knows, we all know. We have always done like this. We know that this is probably the most dangerous complication of all. So the real evolution is not technical, it's cultural. We need to move from individual decision to standardized decision and shared decision. From doing procedure to design a strategy, especially for children. So I'm going to conclude. If you remember only a few things from this talk, I would like that let it be this. There is no universal solution. Early decision matter. Children need tailored strategies. Neonates, newborn children with intestinal failure, children with chronic kidney disease, children with oncohematological disease. So vascular access for them is not a procedure. It's a part of the treatment itself. So thank you for listening to me. If you want to ask me a question, I don't know if you like. This is my team, which I have the pleasure to work every day. And thank you for your attention.